So I'm going to take you through the pathophysiology of infections in sickle cell disease, why these children are prone to infections, and if they get infections, why are they prone to overwhelming sepsis. So there are two main mechanisms that mainly happen. So one is they have an impaired splenic function, and they also have defects in their complement activation system. And other mechanisms could be things like micronutrient deficiencies and mechanical factors. But the two main ones are the hyposplenism that they get, and also defects in their complement activation. We know that children with sickle cell disease get hyposplenism. They get, before the age of 5 years, sometimes it can go up to 8 years, and it can start as early as 6 months because of the recurrent VOCs and recurrent sickling within the spleen. The spleen undergoes ischemia and infarction, and ultimately undergoes atrophy. And we know that the function of the spleen in fighting of infections is first of all a phagocytic filter. It removes old and damaged blood cells, and also it helps to sieve out some microorganisms from blood. And because they have no spleen, they don't have this added function, so they are prone to infections. And also we know that the spleen has a role in producing antibodies as well. So because they undergo asplenia, they don't have these functions, these added functions of the spleen, like the phagocytic filter and production of antibiotics, so they have increased susceptibility of infections. And the infections the main organisms are the encapsulated organisms, which she talked about, the strep pneumoniae and the Haemophilus influenza, all the rest. And we also know that most asplenic children lack IgM memory B cells, because some of these memory B cells are stored within the spleen. So because they lack these memory B cells, they cannot mount a rapid response to these encapsulated organisms. So when they get the infections, they can't fight it off immediately, and so their immune systems are compromised, and so they build up severe infections. The other thing that causes them to have infections is defect in their complement activation. Again, it all comes from the asplenia which result from the asplenia. They get deficiency in the alternative complement pathway, so they don't have opsonization doesn't take place. Whereas some bacteria can be directly recognized by the macrophages and they are killed off immediately. These encapsulated organisms, which the sickle cell children are more prone to, have to first undergo opsonization. And we know that these children with sickle cell disease are because they have a defect in their complement pathway, the alternative pathway. So they don't produce those complement components, the factor B and the C3, to coat the microorganisms. So it cannot be killed off effectively, so they get overwhelming sepsis. So other things like micronutrient deficiencies, things like micronutrients like zinc have been found to be important in the immune function. So low levels in children with sickle cell disease have been suggested to contribute to their susceptibility to infections. So studies have been done, and have found that children with zinc deficiency is associated with lymphopenia and reduced production of interleukin-2, and there's also reduced natural killer cell lytic activity. So because of these factors, you don't have white cells to fight off your infection. The natural killer cell activity is reduced, so their ability to fight off infections is impaired, so they are prone to infections as well. And mechanical factors, we know that these are mainly what predisposes them to osteomyelitis mainly, because we know the pathology of sickle cell is the vessel occlusion and the hemolysis. So with the recurrent vessel occlusion within the bone, ischemia and infarction of bone, so you tend to get necrotic areas within the bone because of this recurrent ischemia and infection. And we know that necrotic bone acts as a foci for infection. So that's what predisposes them mainly to the osteomyelitis as well. So this also has a role to play in the infections that they get. So how will these children present? You're going to take this mainly from history and your examination. So the history is going to be really broad because it's a septicemia, it's a bacteremia, it's sepsis. So you're going to take history targeting every system. They'll definitely have a history of fever. And most times the fevers are really high grade, greater than 38.5. And you're going to look out for symptoms with focus. So it can be a chest infection, it can be a UTI, it can be osteomyelitis, it can be meningitis. So you're going to look out for infections suggestive of that to help you come to a diagnosis, to get a focus of their infection. So if it's a pneumonia, like a patient who initially had a pneumonia, which was complicated by the empyema, he had a cough, he had difficulty in breathing, he had chest pain, examination, he had tachypnea, he was a very sick child. If they had urosepsis, they'll have signs of a UTI. If they have osteomyelitis, they'll have swelling of the bone, tenderness, it will be warm, it will be red. So you look out you take a detailed history basically, and do a crawl complete exam to find out the focus of these infections so that you can ultimately manage your patient. So investigations. So you want to do baseline investigations, of course, to find out how's the severity, to find out the organisms. So you need to do a CBC, the complete blood count, and you're looking out for the white cell count and their differentials, the white cell count may be elevated or it will be reduced. You can have a leukocytosis or a leukopenia. With the differentials, you look at the neutrophils and the lymphocytes as well, which will guide you. You need to do blood cultures, mainly to identify the offending microorganisms and also get the right drug after the culture and sensitivity. You need to do urinalysis with urine cultures. You can do a CRP, procalcitonin, though these would be important during early sepsis mainly. And also you can do CSF if you suspect meningitis. So the investigations you do are going to be broad, will depend on the clinical presentation of the child, and they will guide you, the child will guide you what to do, but the baselines have to be done. And not forgetting the imaging as well. You can do chest x-rays if you think it's a pneumonia, if the focus is the chest. You can do bone x-rays if you think the focus is osteomyelitis. You can do an abdominal ultrasound if you think it's an abscess. So all this will depend on how the patient presents. Yeah, thank you.